Wendell Stone, 52, chief rigger from Pitt Fest. Isolated trauma to the left chest when a speaker tower came down on him. Looks like multiple rib fractures. Pulse 110, BP 130 over 85, decent stats at 96, 50 of Fent in the field.
Got it?
How we doing, Mr. Stone?
Mr. Stone was my dad. It's just Stone.
So, this looks like a case of blunt chest trauma with multiple rib fractures. Just an interesting thing to note in rib fractures medically is that if 3 or more consecutive ribs are fractured in 2 or more places, we call it a flail chest. Here, the flail segment moves in the opposite direction to the rest of the chest wall. It goes in while the rest of the chest is moving out, and vice versa. Hence, it's called paradoxical breathing. Getting back to the case here, the vitals aren't that altered here. Slight increase in BP and pulse is expected in case of trauma. 50 of Fent means the patient was given 50 micrograms of fentanyl, a powerful synthetic opioid, which acts as an analgesic here. Chest X-ray, CT thorax, USG fast scan are to be promptly done to rule out life-threatening conditions like tension pneumothorax, which means collection of air inside the pleural cavity that progressively expands and compresses lungs, leading to lung collapse, hemothorax, or collection of blood in the pleural space.
No abdominal tenderness.
Tenderness means pain when the abdomen is palpated. Basically, abdominal tenderness is checked in every quadrant of the abdomen and signifies specific pathologies accordingly. No abdominal tenderness means likely no pathology in the abdomen, although there could be internal damage to organs inside due to blunt trauma here. The resident here is doing a fast scan, an ultrasound to check for any blood collection in body spaces.
Yes.
What do we got?
Thanks. You owe me a Coke.
Isolated chest trauma
Stop.
with...
I want to hear from Dr. Santos. Isolated chest trauma with obvious flail chest, no pneumo on poke.
We discussed all of this just before. Flail chest with multiple rib fractures. Flail meaning the rib fracture segment is separated from the rest of the chest and moves opposite to the normal chest wall movements. No hemo-pneumo means no hemothorax and pneumothorax, ruled out here using fast scan.
Guess good stats and vitals.
Excellent presentation. Sir, I'm Dr. Garcia from surgery.
I need surgery?
Not necessarily. No blood in the belly on fast.
Okay.
So he is saying that the fast scan doesn't show any blood in the peritoneal cavity. We check for blood or any fluid collection in the potential peritoneal spaces, like Morrison's pouch between the liver and the right kidney. If there is any, we would call it hemoperitoneum. We saw the case of hemoperitoneum in episode 2 as well. It was a case of gunshot wound to the abdomen where there was internal bleeding with blood filled in Morrison's pouch. It was shifted to OR for explorative laparotomy to stop and repair the bleeding site.
You got this?
Abdomen's benign.
Benign abdomen means the abdominal examination is normal, with no signs of acute pathology. The abdomen here is soft, non-tender, non-distended, with normal bowel sounds, with no rebound tenderness, meaning pain after releasing pressure on palpation, and no tense abdominal muscles during palpation, which would otherwise be called as guarding.
CT chest, abdomen, pelvis with contrast. Which I trust way more than your ultrasound skills.
Of course, CT scan would be much more detailed than a bedside ultrasound done. Ultrasound basically detects if there is any free fluid collection in any body space. It can be used immediately in primary survey and does help rule out potentially fatal conditions right away bedside, like hemopneumothorax, cardiac tamponade, or hemoperitoneum. A CT scan with contrast, however, on top of all those, would also help provide more detailed imaging of solid organs and help detect injuries in liver, spleen, kidney, bowel, and active bleeding. A USG can be done immediately in unstable patients before primary management as well, while CT does take time and is done when the patient is stabilized enough.
Exit!
And more morphine, for God's sake.
No. Don't knock me out. I gotta stay on top of the crew doing the pudding.
The what?
The festival.
We'll block all the nerves going to the broken ribs. Roll to the right. You'll be awake and pain for...
Morphine is used as an analgesic here. However, as we increase the dose of an opioid, it will definitely have sedative effects. We've learned with fentanyl cases here that opioids could even have respiratory depressant effects that could cause overall hypoxia and drop in saturation, and if not monitored properly, patient could go into respiratory arrest and die. The resident here is going with a much safer anesthetic approach here to numb the nerves supplying the ribs. It would have a localized effect as it's local anesthesia, not general, so the patient would naturally be awake with just the targeted pain relief.
Yeah, that's what I'm talking about.
That's a ton of intercostal block.
She's alluding to whether it's an intercostal nerve block. Intercostal nerve block means injecting local anesthetic near the intercostal nerves. However, since multiple ribs are fractured here, multiple intercostal nerves are to be anesthetized. This means multiple intercostal nerve blocks for multiple intercostal nerves supplying multiple broken ribs, which is what she was alluding to, which can be cumbersome.
Nope, one shot. Serratus anterior blocks down to T9.
Serratus anterior block, or SAB, is a regional anesthetic technique that's increasingly used for rib fractures and thoracic pain, and even for post-operative analgesia. The block is performed at the level of the fifth rib, where the serratus anterior muscle lies. Local anesthetic like bupivacaine is injected at this level in the mid-axillary line, targeting the fascial plane between the latissimus dorsi and serratus anterior muscles under ultrasound guidance. This block aims to target the nerves that travel through this exact fascial plane, like the lateral cutaneous branches of the T2 to T9 intercostal nerves, as well as the long thoracic and thoradorsal nerves. Which simply means that the anterolateral chest wall of that side would be numbed here, effectively countering the pain due to the flail chest. It's a single shot at that fascial plane and doesn't require multiple injections.
You kids and your crazy regional blocks. Dr. Santos, call me with the CT results. Extension 1121.
The block can be performed in the lateral decubitus position. Hence the patient is turned to one side here.
Okay. How big is the pneumothorax? Got it, thanks.
So the CT has detected a pneumothorax here that the fast ultrasound scan couldn't. It has likely occurred here as there are rib fractures, and fractured rib likely punctured the parietal pleura lining the chest wall, and visceral pleura over the lung, leading to air passing from inside the lung to the pleural cavity, and or air passing from outside to the pleural cavity as well. Usually, the holes or defects in the chest wall and in the lung act as two-way valves, allowing air to pass from both directions. But sometimes they act as a one-way valve, allowing air to get into the pleural cavity, but not out of it. This creates an increasing tension and pressure in the pleural cavity, which eventually leads to collapse of the affected lobe. This is when we call it a tension pneumothorax. Air fills in the pleural cavity, but can't escape outside. This is a life-threatening emergency, with patient experiencing severe chest pain and shortness of breath with low blood pressure. Basically, a hemodynamically unstable patient in distress requiring immediate intervention like needle decompression or chest tube to save his life. Just looking from outside, the patient likely doesn't have this condition. He might have a pneumothorax, not a tension pneumothorax, but it could grow into a tension pneumothorax if not immediately decompressed.
What's a pneumothorax?
Just a little air leaking from the big bruise in your lung.
This is basically caused here by the end of the fractured rib, puncturing the lung tissue, resulting in the leak.
Getting short of breath here.
Pain?
No, all that's gone.
Good, the block worked.
Sats are down to 85 on 5 liters.
So the catch here is that if the saturation is decreasing progressively, this might mean that the pneumothorax isn't just small here, it's getting larger, collapsing more of the lung, which translates to less surface area for gas exchange. This might also be a sign of progression to a tension pneumothorax, where the trapped air is not able to get out due to a one-way valve in the lung defect or in the chest wall defect, causing more parts of the lung to collapse. This ideally requires immediate decompression via a needle or a chest tube to prevent this progression. Let's see what happens.
His lung contusions need some help. Start BiPAP, 10/5.
BiPAP means bilevel positive airway pressure, with inspiratory pressure being 10 and expiratory pressure being 5 here. As we know from previous episodes, BiPAP uses positive airway pressure to ventilate the lungs. However, in a patient showing signs of a progressive pneumothorax, the positive pressure given forces air with even more pressure into the pleural space and worsen the air leak, which would expand the pneumothorax even more, and if not already, convert a simple two-way valve pneumothorax to a one-way valve tension pneumothorax. So, I don't think this is the right thing to do. Immediate decompression with a chest tube would be ideal in this setting.
That'll open up the bruised parts of your lung.
Yeah, it would open up the bruised area, meaning would better ventilate the area of trauma to lungs here, but this would also force more air into the pleura through the defect, now with even more pressure. This is a very bad idea. If the patient has a pneumothorax, never start BiPAP unless a chest tube is in place, because this can worsen his situation.
Thanks.
Good news is you don't need surgery.
He does need a chest tube though, at least. So, this scene tells you the importance of consulting with your senior before giving orders here. Mistakes like this could be fatal to the patient.
But I'll let Dr. Garcia know about the CT.
She likes you.
I've met her 2 hours ago.
I don't know if she would like her after she informs her about putting a pneumothorax patient on BiPAP instead of just going for decompression.
Must have made a strong first impression.
In med school, first impressions do not matter if you make a potentially fatal blunder due to your carelessness. That's an everlasting impression of you for people who witness.
What's going on?
Hypoxic to 78, BP's crashing, systolics 82.
What we guessed would happen before exactly happened here. A patient with pneumothorax was under BiPAP, and now he is hemodynamically unstable with low BP and decreasing oxygen saturation. Doesn't it sound like the pneumothorax progressed into a tension pneumothorax, which is increasingly expanding due to the positive pressure given via BiPAP, leading to lung collapse and hypoxia here? As we discussed before, the patient should have been decompressed immediately with a chest tube instead of putting him on BiPAP that further worsened this into a life-threatening situation now.
Pulse is thready. I should intubate. Does he need a massive transfusion protocol?
This girl is always ready for a procedure no matter what it does to the patient. Instead of trying to identify the cause of the patient's deterioration, including her grave and potentially fatal mistake, she wants to intubate the patient and provide even more pressurized air into the lungs and feed the pneumothorax even more, worsening the situation. Instead of doing the exact opposite here, which would be to remove this air from pneumothorax by decompression via a chest tube. This is what happens when you take decisions on your own without consulting a senior, and when you are too oriented towards procedures rather than taking a breath to analyze what actually happened to the patient in the first place. I discussed a case where an intern friend provided a patient of pulmonary edema with furosemide without taking into account his low BP, and the patient almost died. This is a similar case here.
No! Absent breath sounds on the left. Tracheal deviation to the right.
These are basically the signs of a tension pneumothorax developing in the left lung here, where there were rib fractures. The classic clinical examination signs of a tension pneumothorax include: on inspection, we would see rapid labored breathing with the affected left side expanding less than the right. We could notice the use of accessory muscles like sternocleidomastoid signaling respiratory distress. We could observe distended jugulars as the venous return is compromised here due to high intrathoracic pressure. On palpation, there will be tracheal deviation to the opposite side as the building pressure of the pneumothorax shifts it to the right side. On percussion in the affected chest side, there would be hyperresonant note due to the excess air inside the left side of the chest. On auscultation, meaning upon listening to breath sounds via stethoscope, there would be reduced or absent breath sounds on the left side as the excess air building up blocks the transmission of breath sounds.
14 gauge angiocath.
Finally, a needle decompression will be done via a 14 gauge needle here. Usually, a large bore that is 14-16 gauge angiocatheter is used. This could have been done as the initial emergency measure here as soon as the slightest hint of progression into a tension pneumothorax was noted with the progressively decreasing oxygen saturation of the patient way earlier.
Now put him on a non-rebreather.
A non-breather mask doesn't provide positive pressure like a BiPAP and helps oxygenate the patient without increasing the air pressure and pneumothorax inside. The BiPAP is to be removed.
What are you doing?
This is the non-breather mask right here. The maximum limit of oxygen rate here is 15 liters per minute to rapidly correct the ensuing hypoxia due to potential lung collapse here.
Tension pneumothorax from the BiPAP's positive pressure.
Just like we said before, the positive pressure of BiPAP resulted in a one-way valve mechanism where high-pressure air was pushed to the lungs and outside to the pleura as well. The air which was pressured into the pleura failed to return back to lungs during exhalation and outside. This built up the air inside the pleura to the point where the outside pressure increased so much that the lungs started to collapse. This resulted in respiratory distress and hypoxia noted here with the low oxygen saturation. The increased intrathoracic pressure decreased the venous return to heart significantly, resulting in low cardiac output and a state of hypotension and feeble pulse noted here as well. Here, the needle is inserted in the left second intercostal space in the mid-clavicular line. This is the traditional recommended route for a needle insertion. Alternatively, this could also be done in the fifth intercostal space in mid-axillary line as well, basically the same area used for a chest tube. As we've learned in the thoracotomy case before, the needle is inserted just above the lower rib to avoid injury to the neurovascular bundle that run in the costal groove in the lower border of the rib above. We gotta advance the needle until we hear a hissing sound, and then the needle is removed, leaving the catheter in place to vent the excess air out.
You hear that?
This is the sound of the excess air venting out. After this initial emergency step that immediately removes excess air, stabilizes the patient, and removes him out of a life-threatening state of increased intrathoracic pressure, the patient is now to be prepared immediately for definitive management, that is chest tube insertion.
Who the hell ordered BiPAP, Garcia?
No, his sats were down. I did.
You did. Without running it by me.
BiPAP was wrong and could have been a fatal mistake. Also, this is irresponsible behavior on her part to order without being approved by a senior. She did it when she injected local anesthetic in paracervical trigger points herself. He reminded her that time that she shouldn't do it. Now, she did it again, this time with dire consequences for the patient, leading to the patient suffering even more and potentially losing his life.
Can I put in a chest tube?
For her to ask for a chest tube after committing an absolute blunder is just crazy. This isn't realistic to say the least. To be this unaware of the gravity of the blunder committed here. Nobody has the confidence left after such a thing to ask for more procedures.
He doesn't need a chest tube. He needs a pigtail catheter, and I'll be doing it.
A pigtail catheter is basically an alternative to chest tube here. It has a smaller diameter and is more flexible, less invasive, and less painful than chest tube, and can be used if the patient is stable after needle decompression like here, with no indications of blood in pleural cavity. Pigtail is usually used for cases of simple and spontaneous pneumothorax where small drainage is enough. But for a traumatic pneumothorax with massive air leaks, or a tension pneumothorax, or trauma involving hemothorax requiring large drainage, chest tube, which has larger diameter than pigtail, still remains the gold standard definitive management.
Sats and pressure both coming up.
Drop 75 of ketamine.
This means the decompression has worked and rapidly improved the vitals, making him stable enough for further definitive management here. Ketamine is an anesthetic drug to be used for sedation here. I mean, at this point, I wouldn't be able to look straight to a senior after committing a blunder like that. She doesn't realize how serious this is. Mistakes in medicine cost lives, so you gotta be super careful and serious here. We are dealing with real people's lives and not inanimate objects.
Whoa, what did I miss? A little drama from a tension pneumo. You could have called me. We got it under control. Good. And Dr. Santos learned what can happen when you put a patient with a small pneumothorax on BiPAP. Ah.
Yes, if a patient has low oxygen saturation, always look for the underlying cause for it before trying to correct the saturation first, especially if the patient already has a small pneumothorax shown on CT. It should have been clear that the pneumothorax had progressed at that point, and providing more pressurized air to the already expanding pleural cavity will worsen the pneumothorax, causing tension pneumothorax, and will be a fatal mistake as the increased intrapleural pressure leads to lung collapse, obstructive shock due to venous return compromise, and eventually cardiorespiratory arrest if unchecked.
Thumb scalpel.
He was hypoxic. I thought it would help.
But you didn't discuss it with me, and he almost died. Dilator.
She was even talking about intubation, which is a step further ahead taken when even BiPAP fails to increase the oxygen saturation, and that would have been disastrous. You gotta have a medical mindset first, trying to find out the cause, which is obvious here, instead of jumping into a procedural or surgical mindset. This could be a misunderstanding of the pathology of pneumothorax as well, because she said BiPAP would open up the bruised area of the lung, while not understanding that the same pressurized air will also go through that lung defect into the pleura and worsen the situation.
You need to run every order by a senior resident or attending.
That's why it's a 4-year program.
For context, a little bit of my own personal experience here working as a doctor in the ER. While working in the ER during internship where we rotated there throughout the year every few days, and even after that, we, as young doctors, were given the privilege to administer essential medications early. Those essential medications would be meds for simple symptomatic management like meds for vomiting, fever, gastritis, IV fluids for hypotension, dextrose for hypoglycemia, antibiotics for infections, medications for acute exacerbation of COPD, which was fairly common in the ER, or simple suturing for cuts or incision and drainage for abscess. Anything beyond this, we would always consult the ER doctor in charge, especially if procedures or interventions are involved, along with reporting their vitals first. The feedback we received upon consulting a senior would determine the treatment course, including additional next steps, if necessary, as discussed and approved by the physician in charge. And this is also important because if anything happens to the patient, the senior-most doctor in charge has to take the blame. This makes it absolutely necessary to not randomly order without running it through the senior.
Now, when you do this procedure, you want to make sure to never, ever lose this guide.
This is the Seldinger technique used here for pigtail catheter insertion. Here, first the introducer needle is introduced in the pleural space, and then the guide wire is introduced, removing the needle and leaving the guide wire in place. This guide wire will then guide the passage of the dilator over the wire. The purpose of this dilator is to dilate or enlarge the tract. The dilator is then removed, and then the pigtail catheter is inserted over the wire. We gotta advance until the coiled end is fully inside the pleural space, and then at last, the guide wire is removed and the catheter is finally secured with suture that helps drain the air from pneumothorax here.
If that gets sucked in the chest, you're screwed.
This could occur if you let go of the proximal end of the wire during the procedure, especially when advancing the catheter without maintaining control of the wire. If you lose the grip, the wire goes into the pleural space and acts as a retained foreign body that requires surgical removal. So, you gotta always maintain grip on the proximal end of the guide wire and go slow.
Now, ready for the pigtail.
What the hell are you doing? Pneumo is tiny. It'll resolve spontaneously.
Yeah, it was tiny until the patient went on BiPAP.
Are you kidding me?
Guide wire out.
He has removed the guide wire, which means the pigtail catheter has been inserted and is now to be secured there with suture.
His sats were down. I gave the order.
Without clearing it with me.
Honest mistake from the rookie. That's how we learn.
No, that's not how we learn, at least not encourage the girl here to do similar thing in the future. We can't make fatal mistakes here, especially when it could have been easily avoided. See, mistakes do occur in medicine that might cost the life of a patient even with guidance from a senior. But here, it's a blunder that could have been avoided if she had obeyed her resident, who had reminded her not to take solo orders before, and if she had consulted him instead of ordering it herself. So, this is not really acceptable as she herself wasn't responsible enough, even after being warned of doing such a thing by the same resident, after her solo administration of paracervical trigger injections.
If she knew everything, she'd be your attending, not an intern.
Yeah, so, because of that, the point here is to ask your senior if you don't know, instead of trusting your instincts and passing orders without any consultation. And you should be aware of what you don't know as well, and respect your seniors enough to vouch for their opinion first.
That is very true.
Besides, it could have happened on its own without the BiPAP.
Yes, it could have happened on its own, as the warning sign of progressively decreasing saturation was there. If it was left to naturally progress, the pneumothorax would have likely resulted into a tension pneumothorax as well, and this was right before she ordered BiPAP, at which point the needle decompression should have been done, instead of ordering something that has the exact opposite effect of decompression, worsening the already progressive pneumothorax.
Wow, beautiful moment. A lot of love in the room.
If you'll excuse me, nice save.
I do think the two girls here have the same kind of personality. This type of toughness is required to an extent to become a surgeon, but not to the extent where you commit fatal mistakes that could have been easily avoided.
Your scabs don't know zip ties from airline cable? On and find out. Come Monday, that promoter's gonna have my lawyer's shoe so far up his ass, he's gonna be flossing with the laces.
How are we doing in here? Vitals are perfect, setting 98 on 4 liters.
So the pneumothorax patient is stable now. His mask has been changed from a non-breather mask to nasal prongs now as the saturation has significantly improved back to normal. The resident did really save his life here.
Nice. I could go back to work now.
With 6 rib fractures, a bruised lung, and a catheter in your chest, not the best idea. But I do respect the work ethic.
The pigtail catheter in a case of pneumothorax will be removed only after the patient is clinically stable with normal vitals and no respiratory distress. The left lung is fully re-expanded on chest x-ray with no air leak on water seal, and that would require a lot of time itself. A pulmonary contusion or bruising can worsen over 24 to 48 hours, so close monitoring is key here. Also, about the flail chest with multiple rib fractures requires supportive care with ongoing pain management, close monitoring for saturation. Surgery might be indicated in cases of severely displaced fractures. The surgery here is open reduction and internal fixation of broken ribs with plates and screws.
Richie, get Cecil on FaceTime again. I need to see this shit myself.
Do me a favor, call Dr. Gregorian in thoracic and see if he'll take Stone as a personal favor to me and make sure he knows he doesn't need any real babysitting. He's stable, we just need a bed.
Copy that.
Admission to the cardiothoracic ward, where he would be looked upon by the thoracic surgeons and monitored there for any complications, would indeed be ideal for him.